Hello, everybody. My name is Dr. Al Hewer. I am the co-owner of A&T Lectures with Terry Shenfield. I'm a professor at Rutgers University, and I'm the lead adult ICU therapist at Morristown Medical Center. It gives me great pleasure to now talk to you over the next 45 or 50 minutes on a very important topic related to ethics. This particular one will focus on ethical considerations in clinical research to give you an overview. Some of the specific learning objectives we'll focus on are describe the evolution of ethics in clinical research, review the medical ethical principles and definitions, pretty much what you would find if you opened up most any, if you will, medical ethics textbook. The principles and definitions that would appear in them irrespective of the discipline that you were in. So we'll cover that broadly. Then we're going to look at how they apply in clinical research. We'll review some of the strategies to help avoid ethical problems and pitfalls, and furnish you with additional resources on how to find additional information if you're interested in drilling down more on these topics. The definition and classifications of medical ethics. So the definition, again, this is an excerpt, but basically it involves a system of moral principles governing the conduct of persons in a profession or a population. Now, we give many lectures on medical ethics. For instance, we have one that relates to medical ethics in clinical practice, really at the bedside. This is a little bit of overlap with that one, but this particular focus is on ethical principles in research. Then beyond that, there's ethics in clinical education. And again, as a faculty member at Rutgers University, we sometimes will encounter these ethical issues in, if you will, education with students and honor code issues, and perhaps, students being supposedly not necessarily doing their own work or things along those lines. Okay, so it's something that I've encountered in my past. Perhaps you may have as well, but it's not the main focus of this particular presentation. The essential features of research. So let's start and kind of build this foundation and work from there as we gravitate towards not just research, but ethics in research. So research, kind of by definition, involves, if you will, validating the validity and soundness of research, looking at the ability to prove or disprove a hypothesis. And again, the hypothesis is really the, if you will, foundational statement of research. Many or some of you may have taken 8th grade, if you will, research or science using the scientific method. And that whole method really starts with a hypothesis. So many of you in our audience are respiratory therapists. So an example of a hypothesis could be that a lower tidal volume of, let's say, 6 milliliters per kilogram is safer for most patients than a higher tidal volume of 10 or 12 milliliters per kilogram. We're going to focus more on this actual particular hypothesis, but it'd be hypothesizing that, again, lower tidal volumes are safer and more effective than higher tidal volumes, or a certain drug or dose of a drug is more effective in, if you will, combating bronchoconstriction than another drug. And that hypothesis would be tested in a very structured manner known as the scientific method. Another essential feature of research basically is looking at ethical considerations, so human subject protection, which really is the focal point of this presentation. And then another feature would be, does the research contribute to a significant body of knowledge? Is it a new drug, a new respiratory drug, a new HIV drug, etc.? So this is kind of like the, if you will, the main components of research, and again, of which we're going to be focusing on the ethical considerations in the lower left-hand side of this Venn diagram. History and evolution of research and relating to ethics. Over 100 years ago, there basically were few or no laws governing the development of medications and medical devices. I don't want to say it was entirely the Wild West, but it was much less structured and regulated than it is today. Likewise, there was no or very few ethical guidelines for researchers and participants to follow in research. Now, what happened was, indeed, there are researchers who had, if you will, high moral character that may well have really been very careful about protecting human subjects. But that was sort of voluntary. That was dependent on the actual research team, right? So that you can imagine that there were some, if you will, intentional abuses, or just in the presence of a lack of guidelines, there were ethical issues that arose. Almost anyone could be asked or made to participate in clinical research. When I say anyone, I'm really referring to military personnel, students, prisoners, if you will, populations today that are very heavily regulated more heavily, that is, prisoners, students, other vulnerable populations are very, very heavily regulated. And we'll talk a bit about that over the next 45 minutes or so. And in fact, many or some participants in research were injured. Now, I use the term participants because when we're taking care of individuals at the bedside, they're actually known as patients. When those patients now participate in research, they're known as subjects or participants. And in fact, before the regulations were put in place, some subjects or participants were injured in the spirit of research. For example, the Tuskegee Study. So beginning in the 1930s, almost 400 men signed up with the US Public Health Service for free medical care. Who wouldn't sign up for free medical care? These were, again, men of very humble and modest socioeconomic standing, okay? Service was conducted, and including, a study on the effects of syphilis on the human body. So the men were inoculated with, if you will, the spirochetes, with the syphilis spirochetes, the microbes, but they were never told they had syphilis. And they were denied access not to overall treatment, but to specific treatments that existed for syphilis, even after penicillin came into widespread availability and use in 1947. By the time the study was exposed in 1972, so a long while later, 28 of the men had died of syphilis, hundreds of others were dead of related complications, and at least 40 of the wives had been infected, and 19 of the children actually contracted it as well. And then the link on the bottom here, for those of you who want to learn more about it, is down on the bottom here. And again, it was one of the examples of research ethics gone totally wrong. The McGill University study, so it was much later in the late 1950s, 1960. So McGill University administered psychedelic drugs to 52 unsuspecting patients in order to carry out this brainwashing experiments for the Central Intelligence Agency, or CIA. Experiments disclosed publicly for the first time in 1977. So a lot of years, you can see it takes a lot of years for these to fulminate or be made public. It's not until 1988 that the survivors received the settlement. So it was a long, long period of time. And again, you just wonder, these were psychedelic drugs, these were illegal drugs, and the individuals were not told of what they were taking, why they were taking it, sort of thing. So you can just imagine from 1957 to basically the 1970s, it was there was a lot of things that were going on that were not good in research. Then what we have is going back to just post World War II. So they really looked at codes and declarations. Okay. And the Nazis did, and again, you probably are aware in readings and watching media, whether it be on your computer, on the TV, that the Nazis did horrific experiments on prisoners of war. And these experiments were not well known during the war, but came to light very shortly after the war. And it was as a result of the Nuremberg trials, where the individuals who were responsible for this experimentation on these prisoners of war, they were actually, if you will, tried, the Nuremberg trial. And from that process came the Nuremberg Code. So 1947 Code for Biomedical Research was the first to focus on the importance of informed consent. That individuals participating in research had to be, and this is a descriptive term, they had to receive informed consent. They had to be informed on what was being done, why it was being done, what are the benefits, what are the risks, and they had to be told that you can say no without any retribution, or if you say yes, you can change your mind and withdraw at any time with no consequence. Moving further along in history to the Helsinki Declaration. This 1964 declaration provided guidance in such areas as the use of animals for research purposes. So there you go, a lot of emphasis on humans, but also some emphasis on being ethical when it comes to using animals in the context of clinical research. More codes and laws. The American Sociological Association adopted a formal code of ethics in 1969. The National Research Act of 1974 was passed by Congress for the purpose of protecting human subjects participating in experiments. So these experiments were of all different sites, all different types, all different locations, etc. But it was passed by Congress, and it was another, if you will, layer of protection that was provided to individuals. The APA, or the American Psychological Association, in 1982 came up with the ethical principles in the conduct of human research with human participants. Okay, so they have another layer of protection. Of course, while it's essential to have codes, the responsible for ethical research ultimately lies with the individual research team or individual researchers. Now let's take a gander at the medical principles and concepts. And like I said earlier, pretty much if you were to open up a textbook on medical ethics, you would find at least these 4 principles, in some case more than them. Autonomy. Autonomy has to do with the right of the subject or participant in research to freely participate or not, provided they meet certain inclusion or exclusion criteria. So they can be excluded because they meet the exclusion criteria. But even if they meet the inclusion criteria, they're the right age, right gender, et cetera, they have the right disease, they don't have the right disease, et cetera. But even if they meet all the inclusion criteria, even if they sign the informed consent, that they have the right to withdraw at any time for any reason. Beneficence has to do with subjects being told the truth about the risks and the benefits of their participation. That's where, again, the informed consent document comes into place. It's not just a document, it's a process. It's not just signing, your signature or the subject's signature on a piece of paper. It is truly ensuring whoever is doing the informed consent on the research team that the subjects truly have the capacity to understand, and they do. We have vulnerable populations that are receiving medication, sedation medication, may not be competent. We have individuals who are under severe distress, an asthmatic patient who is, in the midst of an asthmatic episode, okay, that they may be in so much physical duress that they may not be competent to actually objectively sign an informed consent and agree to participate. Individuals with psychiatric disorders, they may be so severe that they are not competent. Then we have the term non-malfeasance. It has to do with, will the research harm the subject? So if it can't benefit them, or if it doesn't benefit them, is it at least not going to hurt them? So one of the jobs, I'll talk in a moment about the Institutional Review Board, is to at least make sure that the risk to benefit relationship is favorable enough where it's not likely that the subject's participation will, if you will cause harm to them. Justice has to do, in this context of clinical research, will all subjects be treated fairly? So whether you're in the experimental group or you're in the control group. So experimental group is getting the, if you will, experimental intervention, the experimental drug. The control group is getting the traditional. Okay, what would normally have been done, before the research was examining, if you will, the intervention. Other factors that come into play in clinical research, there should be no significant pressure or coercion, never any pressuring of participants, needs to be sufficiently safe. So the safety of participants is essential. I will tell you that if you think about it, if the science or experiment or research is being done on a condition that we know is potentially very harmful to patients, like pancreatic cancer, head and neck cancers, okay, where it is more likely than with other forms of cancer that the subject or participant may succumb to the disease. Okay, so that's where safety is. The threshold for safety on a drug that may hold hope for pancreatic cancer, the bar is different than if it's looking at a relatively innocuous intervention, such as meditation, okay, such as participating in survey research, which is it's not very likely to hurt the patient. Okay, they're not likely to die whether or not they participate in it or not. But with a drug that may hold some hope for pancreatic cancer, it does matter. So safety, may not be a major issue for the research. It may be hugely significant. Credit, that every researcher must receive precise, appropriate credit. Communication, one should try to make results known to participants and stop if the interim results warrant. And we're going to talk in a little bit about a particular case. And again, for our respiratory therapy and to some extent our nursing individuals that are in the audience, is that we looked at lower or low tidal volume. Okay, there was a major study that was done by Matei and others that really looked at the lower tidal volume, looked to be much safer and more efficacious. And the study wasn't done, but the higher tidal volume group were actually crossed over. That they did interim statistics. The study wasn't done, but they looked at, wow, the difference in mortality is huge. For ethical reasons, it's unethical to keep the patients in the higher tidal volume group, so let's lower them. Improper research process or use of results, so one should be basically conscious of the possible bad uses of research, misinterpretation of results, and then generalizing them to say this drug is safer when it's really not. Let's now focus on a really important stopgap measure for clinical research. It's a body known as the Institutional Review Board, or IRB. Their main purpose is to protect human subjects in research conducted within a particular organization. Many times, if you will, hospital systems and universities and colleges pretty much universally have the IRBs. In order to be eligible for public funding, grants, academic health centers, and other institutions such as hospitals, Board of Education, they must have an IRB, and the IRB must adhere to certain guidelines. The IRB ensures that the research meets a certain set of criteria. The major ones we'll be discussing in this presentation. The focus of the IRB, about the investigators. Who's the primary investigator? Who is the tip of the spear or owns the actual clinical research? And it's all disclosed. It's not namby-pamby. Okay, when an individual applies for a grant to the NIH, generally speaking, there's one, if you will, corresponding or principal investigator. There's not two. There's certain cases where there can be two co's, but many times they want one person to be the tip of the spear. Who's supervising the study? Who owns it? Figuratively speaking. Do all the study personnel have the appropriate training? Okay, and there's certain training that they have to demonstrate that they've completed, and they need to furnish the actual records on that. What are the general characteristics of the population? Age, gender, etc. Are there any special characteristics of participants? Are they vulnerable in some way? Are they too young? Are they children? Are they alcoholics? Where again, disclosing that could be very injurious to the participants. Are they mentally challenged in some way? Do they have pre-existing conditions? Are they on medications that could render them, unable to objectively agree to an informed consent to participate in the project? Any other institutions or individuals cooperating or co-sponsoring the study? If it's being done by a university, but it's being done at hospitals, oftentimes multiple IRBs will need to, if you will, approve it. How will the subjects be selected? Once they're selected, how will they be assigned to the experimental or control groups? How will they be excluded, etc.? Major IRB concern, the risks, any immediate risk to the subjects, including possibly causing them embarrassment, inconvenience, or discomfort. Are there any long range or long-term risks to the subject? So sometimes you're on a medication, there's nothing that happens imminently, or they're exposed to radiation, nothing happens imminently, but it exposes them or predisposes them to, for instance, developing cancers down the road. Latent risks, if you will. If there are risks, what is necessary, basically to monitor them? How will subjects be compensated for facing such risks? And if you will, just generally the inconvenience of their time for participating in the research. What's being done to minimize risk? So we'll talk a little bit about methacholine challenge. So what had happened, this is public information at Johns Hopkins. A number of years ago, 15 years ago, I was on the IRB at Rutgers UMDNJ. There was a case where they were using methacholine to induce a methacholine challenge, a bronchospasm. And that was part of the research. That was part of the intervention. The protocol basically called for a crash cart that had, the appropriate drugs, that had intubation, et cetera, that called for the appropriate personnel. And what happened was there was an issue where the patient went into status asthmaticus because of the methacholine challenge. And the rescue protocol could not be implemented because the code card wasn't there. On paper, the study looked good. In reality, there were some major gaps. This was a National Institutes of Health, NIH funded project. NIH basically said immediately, you need to stop all NIH funded research until you figure out what happened. You guys have a problem here. Johns Hopkins took it one further and basically said, we're stopping all of our research until we figure out what happened. Something clearly happened. Informed consent document, a gateway document, and the process to participation in human subject research. So again, we talked about that earlier, but it's generally speaking, you have an idea what it is, but it also must first be approved by the IRB. And while that may sound like a pain in the you-know-what, the IRB many times has templates that can be followed, or they can follow. They can be obviously modified to suit the particular research. But the IRB, if you'll emphasize nothing other than this point, okay, and that point being, the IRB is nothing to be feared. They are a potential resource. And I have one of my final slides talks to this issue. So, if done right, if the IRB for researchers if the IRB is contacted by the researchers early on in the process, things can go much quicker, much more smoothly, and it really lends itself to better research. It needs to be signed by the subject/participant or their surrogate, and it needs to be witnessed. Must be administered by the study personnel who've been approved to do so. So the person who's giving informed consent needs to be able to answer some questions about the study if the potential subject or participant has questions. An assigned copy must be kept on record. It can be digital. Okay, sometimes it's a digital acknowledgement type of deal. There's also, if you will, exemptions where we had done a project where we had it was survey research, and it was an online survey, and the individuals, you basically, scanned the QR code or went to the URL, went to the website, put in your information, and then basically there was a slide that came up that basically said, by clicking next, you're agreeing to participate in this project. But before that, it basically said, this is the purpose of the project. This is what we're doing. Our purpose was actually in trying to measure respiratory therapist perceptions of the administrative burden that's imposed on them by documentation and other reporting requirements, by non-direct direct patient care activities. Okay, not going to go down that rabbit hole right now, meaning talk more about that project. But we did an online survey, and I remember we applied for, if you will, an exemption from actual keeping the informed consent on record. And the idea was that we did have a digital record that the individual had read what was tantamount or roughly equivalent to a informed consent document. They read it, they clicked next, meaning that they acknowledged it, if that makes sense. A little more on informed consent, explain, the study, offer to answer questions. Participation is always voluntary. That's mandatory language. What is the time commitment, the resource commitment, any benefits to the participant to be expected? So it can be, we may cure your disease. That rarely would they say that, but there might be some benefit to, to, if it's an asthma medication, to improving your asthma. Okay. So that's really what they're looking at. And many times they're very conservative, that the benefits are not known. So they tend to understate them. They're not known. They may or may not exist and may be related to X, Y, and Z. Okay. Any potential risks and how the risks have been mitigated or managed. And that absolutely, that all participation will be confidential and anonymous. Okay. So confidential means we can link the participant with their identity, but it's confidential. It's kept in a password protected, computer database. Okay, that's confidentiality. Anonymity is when you go to that data, it's de-identified. You don't know who it is. It's not just locked in a password protected computer database, but even if you went in there, it would have subject 1, subject 2, subject 3. There would be no, if you will, definite identifiers. So confidentiality, sometimes those terms are used interchangeably. They're not exactly the same thing. Waiver of informed consent, I alluded to this earlier, must be approved in advance by the IRB, and there's certain categories of research. One of them is retrospective research, where, for instance, you're going into an electronic health records review or chart review, as we can call it now in slang terms. The survey research that I alluded to earlier is another example. There's a few others as well, but just be aware that they're out there. Challenges in informed consent. Difficult for certain special populations to give, if you will, a voluntary consent. I alluded to a few of these categories, children, mentally challenged, critically ill, and it's mainly like an ICU. Think about this for a minute. In an ICU setting, and particularly mechanically ventilated patients, many of them are sedated pretty heavily. So, really it's their surrogate who can give approval or not. Terminally ill patients, we mentioned that because sometimes they're under a different form of duress. They may reach at any hope at all. And any, if you will, overstating of any of those, if you will, the potential benefits may, if you will, coerce them to participate in a project that they otherwise would not. Prisoners, because they're vulnerable, because there is this, if you will, the corrections officer relationship with the prisoner. Clearly, the corrections officer holds the upper hand. Likewise with students, the faculty member holds the upper hand. Military, you have your rank and file, you have your officers and your non-commissioned officers, and then you have your privates and corporals. Okay, so you have this rank and file, and clearly the commissioned officers can dictate, if you will, to the non-commissioned who dictate to the privates. So it's kind of a guarded, where you have this hierarchy, like you'd have in a prison, you'd have in educational institutions, and you have in the military. It's actually difficult to do those projects because they really do not want the prisoner students and military personnel to be taken advantage of. Other ethical concerns in clinical research, so procedural integrity. Did the researchers follow the approved protocol? Data integrity, did they falsify data? And it may just be not data integrity, did they falsify it? Did they check their data, even if they didn't falsify it intentionally? Did they not check it carefully so it was sloppy? It wasn't intentionally falsified. That happens too, but the data integrity was not ensured. Okay, so when these projects get, if you will, published, manuscripts get published, etc., that usually the peer reviewers want to see, how did you check to make sure that the data, at least spot check, that the data that you input into your statistical software was accurate. Plagiarism, did the researchers try to pass on another's work for their own? There's tremendous pressure in academia to publish. I just found out recently that my colleagues and I got a piece published. It's probably one of about 13 or 14 peer-reviewed journal articles that my name's on. I can tell you, and I've been rejected. So I'm not trying to say everyone I've submitted has been successful. I've had successes, moderate successes, and some failures as well. But but there's pressure in order to maintain your faculty appointment to publish. Okay, and it's a hard process. But in some desperate situations, there have been cases where individuals have plagiarized the work of others, or they've overstated their role, okay, and their name has appeared on the manuscript, but they did not contribute to it in a substantive way. So you get those issues that arise occasionally. Scientific rigor. So there's a lot on this slide here, but we're really talking about things like, so COVID-19. What I'll tell you broadly, okay, and I gave this example here, all right. Now this was this example by Spector Badgley was COVID-19 clinical trial and the oversight of major academic medical center, the approach of Michigan medicine COVID-19 clinical trial. Okay, and really looking at things like, the clinicians eager to offer best care in the absence of guiding data have provided patients with COVID-19 diverse clinical interventions. All right, so I can go on and on and on. Okay, that in some cases, what happened? Okay. What happened was very early on in COVID, there were papers that were accepted for publication that they were kind of rushed through the process. And I will tell you that they had to be retracted. And it wasn't one or two, it was fairly widespread. There was such an appetite, there's such a desperation for some, if you will, data on how you treat these patients, both physically, in an ICU, emotionally, et cetera, that there was this rush process that if you will, some journals succumbed to, and these had to be retracted. So it was an embarrassment. So just be aware, it's not common, but there are certain, if you will, periods of time when, if you will, the public and the journals to which they're submitted are more vulnerable than other times. Let's look at some cases, and then we'll come down the home stretch here with some concluding points. So this case looks at informed consent. You observe a physician, I'm not picking on physicians per se, but you observe a physician researcher attempting to obtain informed consent for an experimental therapy from a patient moderate to severe respiratory stress. Let's say it's an asthma medication. Patient's in an asthma, having an asthma attack. Not a good time to do it, because they're in such distress, they may not be competent, if you will, to render that informed consent. Pardon me. Suggested action on our part, tactfully suggest to the physician that the consent be obtained from a surrogate or from the medical POA power of attorney, someone who legitimately has been issued power of attorney by that particular patient. And I say the surrogate may be, if it's a pediatric patient, it may be the parents. If that fails, consider escalating. It's one of those things, hopefully you don't have to, but what some of us may have seen, not in research, but we may have seen situations where individuals patients sign an informed consent for a procedure, not in research, but for a procedure that they're having done, a colonoscopy, a minor surgery, where they didn't read the informed consent. They didn't read the risks. They just signed it. Anesthesiologist came up, said, we're going to give you, some laughing gas. We're going to give you this. We're going to do this, blah, 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 blah. Sign here, and all is good type of deal. Really, what they should do is, I want you to take a moment and I want you to read the entire informed consent and point out the key points. This is what's being done. This is how it's being done. These are the potential benefits, blah, 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 blah. These are the potential risks, blah, 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 blah. Do you have questions? And stop talking and then listen. That's the way it really should be done. Is it always done that way? Typically not. Sometimes it is. Sometimes we get much closer to the way it should be done than other times. Case 2, consenting of critically ill. A research protocol calls for obtaining informed consent on the trials of a new drug to help clear thick secretions in COVID-19 patients. Okay. The challenge, again, is obtaining informed consent on a sedated and critically ill patient. Suggested action, attempt to gain consent from a surrogate or have the surrogate appointed by the courts. Okay. Different states have different rules. For a while, going back over a decade ago, New Jersey was very difficult to do research on individuals that were, let's say, on mechanical ventilators, and they were on, different Diprivan, different medications in order to kind of keep them sedated so they could tolerate all the treatments, including the mechanical ventilation. Okay, very, very difficult. It's eased up a bit from that, but it's still, they take great care that this patient is potentially vulnerable, and it needs to be really done in a particular manner. Interim results, crossover provisions. So a study comparing, this isn't exactly the description of the study that I was describing. Okay. So in this case, the tidal volumes, okay, are 8 to 10 milliliters per kilogram of ideal body weight. Okay. Versus the lower tidal volumes of 4 to 6, the experimental group. So historically, I came out of respiratory school 32 or 33 years ago. Terry was like a year ahead of me in respiratory school. When we came out, they used large tidal volumes. I'm about 175 pounds, so roughly 75 kgs. When 30 years ago, I would have gotten a tidal volume of 650, something along those lines. Now I'm probably getting a tidal volume of around 500, which is about 7 or 8 mLs per kg. And what we know, the reason why that happens is we know that it's much safer and somewhat more effective. Okay, but what happened was, as I alluded to earlier, the interim results, so the study wasn't done. Interim results basically show a much lower mortality rate. It's 31% versus almost 40% in the lower tidal volume group. The appropriate action was the actual protocol called for interim stats be done before the study's done, and look at the results. And if the results are superior, far superior in one group, is to either stop the research altogether or to cross over the group that was at higher risk into the group that was at lower risk. Case 3. So this is Matei. This is the actual, if you will, citation for the journal article itself in 2000. So the findings were that ventilation with lower tidal volumes, 6 mLs, as compared to the traditional tidal volumes, which were 12, okay, were more effective. So control group got 12, experimental group, the lower tidal volume got 6. Trial was stopped after 861 subjects were enrolled. Okay, they targeted a much larger group than that because the interim results showed, again, 39.8 in the higher tidal volume. That was the all-cause 28-day mortality versus 31%. You may say, well, they're both in the 30%. One is 31%, one's almost 40%. When you're talking about a large population of 861 subjects, that difference is huge. The statisticians, and I know I've listed here near the bottom, okay, the p-value. P-value in this case was 0.007. The reason why I raise that is this. This is not a presentation in research methods, but usually the threshold that's used for, if you will, the chance that the results are, if you will, that they're derived by chance, okay, is 0.05, not 0.005 or 0.007, okay? So that would be 0.05 means that's a decimal, but if you turn it into a percentage, it's a 5% chance. 0.05 is 5% chance that the results are by chance. So a 0.05 or less is the threshold. This wasn't that. This wasn't 7 chances in 100. It was 7 chances in 1,000. So what that told us is the 39.8% versus the 31% was a very, very big deal. Rescue protocol. So let me just, I'll cut this one a little bit short and say the disaster, the research disaster that happened at Johns Hopkins with the methacholine challenge is this case. Okay, the protocol to test the efficacy of an experimental bronchodilator called for administration of methacholine. Methacholine is a cholinergic medication, so it will induce bronchospasms, particularly in asthmatics. Then the administration of an experimental agent to relieve the constriction. Okay, you know, what provisions could help minimize. So the actual rescue protocol that I alluded to earlier, you know, the rescue protocol, which includes use of COCAR, trained personnel, you know, the running of, if you will, simulated codes or simulated, you know, issues where the patient, you know, or subject needed to be, needed to be rescued, if you will, with the use of rescue medications, possible intubation, et cetera, that it was the, you know, appropriate to have the plan and to practice it and make sure that you have all the equipment necessary and trained personnel to actually pursue the rescue protocol should it be needed. Coercion, researcher and the faculty member wants to test new skin treatment and asks his students to participate. Some of the students are reluctant because of a variety of reasons, modesty, but agree for the fear of reprisal. So here it goes. It's not just, you know, if you will, skin treatment, but it's the practice of having students participate in research is at times viewed as a dubious practice. It's best to shy away from. It's not that you should never study students' actions, because it makes for even better educational environments, okay, and better content delivery. But it needs to be done in a particular way, and the subjects and the IRB need to be convinced that you've really done everything you could to, you know, minimize or eliminate the appearance of coercion. Okay, one of the ways you can do that is make it completely anonymous and say, we don't know who's participating in this. And by the descriptors, you know, the age, the gender, we wouldn't be able to tell. Okay. So the students would feel like, okay, I can go on this thing and you know, I'm not giving any identifiers. I'm simply answering the question, and there's no, you know, if you will, personal identifying information that I'm furnishing. That's one way you can kind of, when I say get around it, in a very positive way. So we really want you to be as objective as possible. One of the other things you can do is just you're involving subjects, but you're not, meaning student subjects, but you're not their faculty. You're not overseeing them in any particular manner. There's things that can be done, but the devil's in the details. It needs to be done the right way to mitigate these sorts of, ethical risks. A little more on coercion. So the protocol described in preceding case 5, has been revised to recruit subjects, inner city clinic outside of the university. They will offer $2,000 plus free healthcare. The point of this is, there is a point at which the if you will, remuneration, if you will, compensation is excessive. So, $2,000 to some of us, maybe, it's not nothing, but is it enough to, to expose yourself to like a microbial agent? Hopefully not, big deal. But for some individuals who are very desperate, it might be excessive. They might actually take certain risks, get certain injections, give blood draws, be exposed to a flu virus or something along those lines. So, oftentimes, I'm not saying this has never been done, because I will tell you that there was a flu vaccine where that's what they gave, that they inoculated the patient with flu after the receiving a vaccine. They compensated them for up to $2,000, but it was just like, it was really viewed as it's probably over the limit. There were certain things that were done to kind of mitigate some of those risks, and there was some prior efficacy shown for the vaccine. So if the individuals even got sick, there was some evidence to say they're not going to get really sick, more like the common cold instead of a full-blown flu, if they get sick at all. But it's still kind of a dubious practice. Best to keep, what they do sometimes for the children is they'll, furnish transportation vouchers. They'll furnish, let's say, things like, they tend to steer clear of like Happy Meals from McDonald's, but healthy, a $20 coupon to, let's say a game, a gallery where they actually have, video games, or some sort of a healthy food vendor or something along those lines. So something along those lines might be deemed acceptable, whereas $2,000, $4,000 might be deemed coercive. Parental consent, if you will, assent, and just general consent. So protocol is drafted to determine the effectiveness of a program to educate grammar school children on asthma management. We actually did. It wasn't really research. It was done in the context of community service. We got a small grant from one of the publishers to do this. The participants will be administered a validated asthma knowledge questionnaire before and after the program, et cetera, et cetera. The big thing we needed to do is children of a certain age, when they're sufficiently young, you need the parental consent. They don't sign anything. The parents do. When they're in a certain age where you're really kind of talking about, kids that are like 12 to 18, something along those lines, what often happens is both the parent and the child, I'm going to say older pediatric patient or subject, they have to sign, the child signs an assent and the parents would sign a consent. So it's kind of like this dual process that needs to happen. And different states varies, different, there's a little bit of wiggle room with regard to the IRBs and what they require as well. Data confidentiality. So a research protocol is being prepared to obtain tissue samples from cancer patients for future use. Biopsy procedures, obtaining tissue, proper informed consent is clear, it's totally appropriate. Data will be kept in departmental computer used by a limited number of faculty, blah, 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 blah. The problem with this is this. This is actually known as a tissue repository. The IRB has you still need to fill out a protocol, but then there's a separate add-on, if you will, forms that would need to be filled out for a tissue repository. They tend to discourage these open-ended tissue samples as being maintained for open-ended reasons, for future use, okay? They just don't want it hanging around because it could be the Wild West, it could be anything. So they'll typically want at least some sort of direction if they are going to be maintained for future use, with some examples, including, for example, or ones that outright limit, that they're going to be used not for genetic testing, but just for things, for some other form of testing. So you're taking samples, if they're going to be maintained for periods of time, it's a tissue repository requirements need to be, if you will, need to be fulfilled as well. And they'd like a tighter protocol that limits the future use in some manner, specifies. Adverse events, improved protocol being implemented to test the safety and efficacy of a new cardiac medication. Since beginning the study, 2 of the 4 subjects have become acutely ill. So they've had what's called potential significant AEs, or significant adverse events. Okay. So there's adverse events. These events may or may not be associated with the medication being tested. These just may be totally unrelated. But I will tell you, in this case, if there's only 4 subjects who've been recruited so far and 2 of them have gotten sick, they're probably going to stop the research until they can figure out if there's a relationship between the med that they've been given and the type of, if you will, apparent, if you will, adverse reaction that they may have gotten. Okay, so they'll tend to stop that. What happens when I was on the IRB is we would actually get these AE reports. And an AE may be a rash. A SAE may be the patient, went into bronchospasm, or they went into some dysrhythmia or something along, heart dysrhythmia or something along those lines. This last case is really, it's not really a case per se, but it's to reinforce a point I made earlier on. Okay. So in the case you or your team are novice researchers beginning to prepare a protocol for research, which are involved, you have many unanswered questions related to procedures, subject recruitment, etc. Suggested asking consult with the principal investigator for the project and then contact the IRB on any remaining questions. You use them, reach out to them early. They have tutorials. They were an excellent source for resources for novice, and I'll even say more experienced researchers as well. So some of the take-home messages that we're going to focus on. What have we looked at today? So identifying practical resources. Okay. So really looking at, if you're a novice researcher or someone who hasn't done it at all, try to find it, your areas of research, of areas of interest. Okay. And then try to find, by going through the literature, more experienced researchers in these areas and reach out to them. And many of them will welcome research assistance. Okay. And eventually you might end up being, again, one of the names on a manuscript, and really can help build your reputation for you and for your organization. The IRB is also a practical resource, as we've just illustrated. Avail yourself of these existing resources. So not just know they're out there, but use them. Participate in all available research and ethics training within your organization or organizations. If it doesn't feel right, it may not be. So, where maybe you're not familiar with the actual, for guidelines, rules, and laws, but if it doesn't feel right, it's good just to pause, take a pause, reach out, review literature, reach out to the IRB, reach out to your ethics boards, reach out to more experienced, if you will, clinicians and researchers, and, seek their counsel. Exercise common sense and good judgment. So again, going back to, if it doesn't feel right, if your gut says it's not right, it may well not be. Don't let your ego get in the way. So sometimes what happens is you're proceeding ahead with a research protocol, and for some reason you can't recruit the proper number of subjects. The data you thought you were going to be able to collect, you can't. The medication's not available. It's any number of reasons. So you can always take what you're doing and modify it. If you do modify it in any significant way, you need to go back to the IRB and you need to, if you will, apply for a modification. If you can only get, 50 subjects instead of 100 in the time that you've identified, then and again, that may be an adequate number. It may not, but it may be an adequate number. There's what's called power testing, so that you can determine in advance how many subjects you need in order to show if there's an effect from the, from the intervention or interventions. So, but if you've identified that you're going to have at least 100 subjects and you only got 52, it's a good idea to go back and modify appropriately. If you have questions or need additional information, ask from all of those resources that I just identified a little bit earlier. Last slide we have here is just, selected references. I actually put Egan's Fundamentals of Respiratory Care on the top there for this reason, that one of our colleagues, Rob Chatburn, does a real good job on one of the chapters in there that really talks about research, talks about some of the issues we talked about here and others as well. We've listed other, if you will, resources here, including Anthony DeWitt, the third to last, if you will, reference here, a respiratory therapist legal answer book. So that's more the legal side of things. It is a bit dated, but those principles are tried and true that he references in there. So he talks about it. It's mainly legal, but he also talks about some ethical issues as well. And then the other references that we have here as well, including the American Association of Respiratory Care. I want to stop here, and I want to say that I want to thank you very much for attending today's lecture. We hope sincerely that you got something out of it. And we hope that you also come back to us for your continuing education and knowledge acquisition needs, if you will. Thanks a lot and have a wonderful day. Bye.